I am now honored to introduce Dr. Eric Singer. This is an interesting topic for me personally, because another question we're often asked is whether this cancer is caused by genetics. And should we all get genetic testing? And we're going to hear that answer. What do we tell our children? I recently found out I was a BRCA1 carrier, and I had to tell 3 daughters that they had a 50-50 chance of being a BRCA1 carrier. And thankfully, they all got tested, and they were all negative. But we were trying to figure out which daughter could better manage a double mastectomy and getting a hysterectomy, because that's what they were all thinking. So it's a really fascinating question. We are very fortunate to have Dr. Singer, Eric Singer, speak to us on this very important topic. A little bit about Dr. Singer. He joined us for the faculty of Ohio State University Comprehensive Center as a professor of urology and bioethics in 2022, after spending 10 years in leadership at the Rutgers Cancer Institute of New Jersey and the Rutgers Robert Wood Johnson Medical School. He completed a clinical and research fellowship in the urologic oncology branch of the National Cancer Institute. He received his medical degree with honors in research from Georgetown University, along with a master's degree in bioethics. Dr. Singer performs his general surgery and urologic surgery training at the University of Rochester Medical Center, where he also did a fellowship in clinical ethics. He has completed certificates in clinical research from the NIH and the Harvard T.H. Chan School of Public Health, a master's degree in clinical and translational science from Rutgers University, and a certificate in safety, quality, informatics, and leadership from Harvard Medical School. Clearly went to some better schools than I ever went to law school, so congratulations on that. At the James Center Hospital and Wexner Medical Center, Dr. Singer is the Dave Longaberger Endowed Chair in Urology, Chief of the Division of Urologic Oncology, Director of the Urologic Oncology Fellowship Program, Co-Director at the Disease Specific Research Group, and Chair of the Ethics Committee. Dr. Singer's research is focused on the development of new treatments for patients with genitourinary malignancies through clinical trials. His interest in bioethics includes consent and capacity, research ethics, surgical innovation, and surgical ethics. Thank you. Congratulations.
Thanks so much.
I like your sweatshirt, kind of.
Thanks so much for the opportunity to be here. It's great to see everybody. So we're going to talk a bit about hereditary and familial kidney cancer. So, all right, we're up and running. These are some disclosures. None of them are related to the presentations that are going to be happening today. I want to, again, I am a surgeon, also involved in clinical trials, give systemic therapies, but I am not a geneticist. And so my partner, Lindsay Byrne, who is a geneticist, helped with some of these slides as well to make sure we're getting really accurate and timely information. So in terms of objectives today, who is appropriate to get genetic counseling and testing? Well, what are some of the ways we do this, and what does familial and hereditary kidney cancer mean? Talk about a little bit about the process, and then highlight a couple of recent breakthroughs that really specifically highlight treatment paradigms for hereditary kidney cancer. So this is, again, talking about what does a genetic counselor do when you see someone like Lindsay. She would be able to sort of go through your family history, help figure out, is there really a risk there that needs to be assessed further? What would that entail with genetic testing? What steps in terms of testing would be done? Order and then help interpret those tests. So there's pre-test counseling and then post-test counseling to help put that information in context. Help address any concerns that you or family members may have, and then decide if there's anything that needs to happen going forward, making sure you're connected with the right care providers, or if there's something that needs further clinical investigation, whether to do that standard of care or through a clinical trial. Again, that idea that really a clinical trial is right for any time. So I like to talk about clinical trials from the very first time I meet someone, and then also we reevaluate that opportunity for clinical trials if there's a need for a change in treatment, if there's progression, if there's recurrence. Those are all times to talk about trials as well. This is just illustrating that a bunch of kidney cancer-focused people got together to think about when it is we should be offering counseling and testing for genetics. Some of this has been touched on already. So from a provider point of view, is this something that's going to help us come up with a treatment plan or a surveillance regimen based on whether you do or do not have a hereditary syndrome? Patients may want to know, again, like was being mentioned, BRCA as well. So how does that play into our health maintenance and what kind of screening we're going to do, both for me as someone who's both parents for BRCA and I have it, and then figuring out at what point we engage that with our children. Some of this has been touched on already. Who should we think about doing germline testing? So again, germline is referring to the genetics we pass on. So something that would be in the sperm or the egg. So something that can go from generation to generation. If we talk about somatic testing, that's talking about we're looking at something in the tumor specifically. So that might be something in the tumor, but that's not something that would go on to a child or grandchild that's unique to the tumor. So we're talking about who should get germline testing. Again, age. This is based on a study that was done by Brian Shook, who's at UCLA when he was at the NCI, and sort of saying, yeah, if we look at people who present 46 or younger, those are folks who had an increased likelihood of having a hereditary syndrome. Bilateral or multifocal, you'll see a picture of that coming up. So often sporadic, meaning just random kidney cancer, you get a tumor. If we're thinking more hereditary, we're looking at bilateral, so both sides, multifocal, more than one tumor in each kidney, and again at a younger age. And then as come up in a couple of the presentations, sometimes our pathologists will say, hey, this really looks like a tumor that's associated with a specific hereditary condition, and that would be another trigger for us to think about discussing testing. So one of the things that comes up quite a bit with genetic counseling and testing is what might be some of the ramifications of that other than just the information, yes, I have this genetic change, or no, I don't. With the passage of the Affordable Care Act, there is a component of that prevents you not being able to get health insurance based on a pre-existing condition, which is what some would consider a hereditary cancer syndrome to be. So that's helpful. We also have the Genetic Information Non-Discrimination Act, GINA, which would prevent workplace discrimination. However, disability insurance and life insurance are not covered under either of those things. So again, if you're thinking about, I've been tested, I'm now going to talk about my kids, well, wait a minute, what things do we want to perhaps make sure we have in place before going ahead and doing something like that? So that's, again, where our genetic counselors are so critical to not only making sure we understand the right context for do we need to test, also helping us figuring out what we're going to test for, but then also helping us put it into the bigger context of our family units. Talking a little bit again about genetic testing and results, can either be done by blood or sort of a mouth swab with saliva. There's lots of different genes that they're able to look for. Again, what gene panel they choose to order will be based on your family history and what we're looking for. So often mine is sending to Lindsay. I'll say, hey, papillary kidney cancer, young age of onset. So she knows that she's going to be looking for specifically HPRC and some hereditary papillary renal cancer and some other things. But she will go through and do that detailed medical history to see what else we might want to test for. The turnaround time is very fast now, and the cost of this is much, much more manageable than it had been, often $100 or less. When we get results back, we're often talking about, okay, what did it show? So there could be something that's positive, meaning there's a specific change in a gene that we know predisposes someone to a type of cancer. There could be no mutation detected, so negative, it's just like everybody else. Or what we sometimes see is the variance of uncertain significance, or VUS, and we don't know. Typically, that we don't know is really most likely a negative. So something that we don't really need to worry about, but every once in a while we do see something that does factor in with someone's medical history and may say, hey, we need to be making sure you're getting colonoscopies more often or other things. So sometimes we find results that are not just kidney specific, and again, that depends on the pre-test counseling. Again, post-test counseling, really important, helping to figure out how to put this in context and deciding how and when and to share and with which family members, what's comfortable for you. And then what can we do to take steps to make sure that your health maintenance and screening is going to be most appropriate given this new information. This is just mentioning that if someone is tested, there are often additional opportunities to test other family members for an even reduced rate. So essentially, if sort of cascading the testing, so if I tested positive and my brothers now want to be tested, we'd be able to get them done even faster. So we'll talk a little bit about cancer genetics and kidney cancer. This has already been addressed a little bit. The vast majority of kidney cancer cases are sporadic, meaning it's random. It's a side effect of us living longer than we have in centuries beforehand. So sort of the side effect of living longer is that we have an opportunity to develop some of these other malignancies. So sporadic, the vast majority of cases. You then see hereditary and familial. So again, we'll specify sort of what those two things mean. Familial meaning you may have a strong family history of kidney cancer, but there hasn't been a specific gene that's been identified, where with hereditary, like was mentioned earlier, the really typical or exemplar of that would be something like VHL, von Hippel-Lindau syndrome, where there's very specific genes, a gene that we know, and the physical manifestation is very specific. So familial, you've got first or second degree relatives, that increases your risk even in the absence of knowing a specific gene. With sporadic, again, as was touched on a little bit earlier, there are some risk factors: obesity, smoking, some potential toxic chemicals. Really, this is most likely found that this is incidentally found because of imaging done for some other cause, and we can think carefully about what we want to do with those, ranging from surveillance to biopsy, ablation, resection, lots and lots of options for that. When we think about familial cancer, again, these are folks that we're talking about first or second degree relatives, so other people in your family who have kidney cancer, but we don't know a specific genetic syndrome. In the red box over on the far right, you'll see essentially what they're talking about, the odds ratio. So how much more likely is it for you to have cancer, kidney cancer, if you had first or second degree relatives who had kidney cancer? And the biggest one, if you've had 2 or more first degree relatives with kidney cancer, your risk of kidney cancer goes up 6 times. So again, us getting more nuanced in understanding how kidney cancer works. We'll now talk a bit about hereditary kidney cancer. So knowing kidney cancer that's associated with a specific genetic alteration that we know about. So again, somatic mutations, that's in the tumor that doesn't get passed on, versus the germline mutations, which are in the gametes, the sperm, the egg, and those can be passed on. When we're thinking about germline versus somatic testing, there's some questions that we're asking. When we're thinking germline, does this put you at increased risk for another cancer or other family members at increased risk? Who should be tested? What kind of test should be done? Where with somatic testing, we're really looking, hey, can this help us guide a treatment for this specific tumor? Again, that was one of the real drivers of the whole idea of precision medicine. Is there a specific alteration in this tumor, in this patient, that we can then pull a medicine and say, this medicine, which targets MET, is going to be great for this patient with papillary kidney cancer, and that tumor has a MET amplification, so we should go ahead and match those two things together and potentially get a better result. This you can see here is sort of the schematic going back to biology class, where you can see the idea of the two-hit hypothesis. So if we each get a gene, a copy of something from a chromosome from a parent, all right, and if one shows up as being altered, that means something only has to happen to one of those copies, and now both copies are affected, and now we are affected with that syndrome. So you can see if you come in on the bottom part of the screen with one alteration already, there's only one additional alteration that's needed, and you can get tumor development potentially sooner. And that's why we often use age as a potential risk factor for saying who should need additional testing. This is essentially a paper by Marston and Linehan from the NCI, and looking at all of the different, or the majority of the different kidney cancer histologies, and then the top sort of line is what the histology is, and then the bottom in italics are the genes that are associated with it. So if you think of kidney cancer like ice cream, there's lots of different flavors. Okay, so clear cell, maybe something like vanilla, where if you then get to your HLRCC associated, that's something more like Rocky Road, a favorite of mine, but not in the top most common thing. All right. One of the things that's important when we're thinking about some of the different hereditary pieces is what should we be doing with management? All right. So surgical management specifically. So here's an example of a patient with HPRC, hereditary papillary renal cancer, bilateral multifocal tumors. All those bumps are papillary kidney cancer. And so you can see the challenge when patients are going to be developing bilateral multifocal tumors. How do we balance cancer control? So at what point do we go in and intervene? How many partial nephrectomies can we do? How many times can we go back through the same incisions? And the risk of keeping working kidneys. How do we keep people alive and not developing metastasis? But also, how do we keep working renal units and not having people on dialysis? So that's a lot of work that's come out of the NCI. Again, here's a list of sort of all the different things. For hereditary kidney cancer, we often employ what we call the 3-centimeter rule. Anybody heard about that before? Okay. So the idea is when the largest tumor in somebody who has bilateral multifocal tumors, when the largest tumor gets to 3 centimeters, that's our trigger to go and do surgery. And at that point, we would go and try to remove as many tumors, sort of all the things that we can, sort of really clean out that kidney, because based on the NCI series with VHL in their clear cell, they found that no patient treated following the 3-centimeter rule with VHL developed metastasis. All right, so great. We're achieving our goal of not having kidney cancer spread, and we're now limiting how many times we're going to have to go back in. Because if we did it sort of every time something showed up on a CT scan, boy, people would have a lot of surgery, and eventually they lose their kidneys. So you can see here the list. We've got some that fall under the 3-centimeter rule, VHL, HPRC, hereditary papillary renal cancer, Burt-Hogg-Dubé. So there are some that follow that, but it's also really important to remember that some don't. All right, and so things like HLRCC that was mentioned earlier, hereditary leiomyomatosis and renal cancer, that's an aggressive tumor. That's something that can spread well before that 3-centimeter rule. So that's something where we intervene as soon as we see something on imaging in someone who is affected with HLRCC with an FH mutation. And there are some others that are listed here that we would do immediate surgery. So again, you'll hear the theme. We want to have you go to places, high volume centers with high volume providers who have experience with familial renal cancer, so we make sure we're matching the right treatment to the correct problem. I'm now going to pivot a little bit in the last couple minutes, talk about two examples of medical management of hereditary renal cell carcinoma. We just talked about the surgical side, so this is the medical side. And so this is an exciting case of belzutifan, so a HIF inhibitor. Belzutifan just made a bunch of news at ESMO with some important studies that just came out. This is really exciting because this was a new class of drugs. And here you see again the prototypical clear cell image, VHL, clear cell, which is associated with VHL. And here's a schema, a cartoon of all the different organ sites. So we think VHL, as a urologist, I think kidney and adrenal, but there's also a bunch of other things that come into play. All right, so we've got CNS hemangioblastomas, eye, ear, pancreas, epididymis and broad ligament. So there's all sorts of manifestations of VHL. And you can see from this cartoon here, when VHL is all altered, you have loss of chromosome 3p, causes some downstream effects, and you get this buildup of VEGF. And as was mentioned, targeted therapies, your sunitinib, your sorafenib, your pazopanib, tivozanib, all these amazing drugs came to target VEGF. Okay. But what's right upstream of that is HIF, hypoxia-inducible factor. And so belzutifan is a HIF inhibitor. So it targets that buildup of hypoxia-inducible factor. So a new way to treat the downstream manifestations of having an alteration in the VHL gene. And so this study took patients who have VHL, and they had to have a kidney tumor present in it, and then they were given belzutifan to see what happened. And you can sort of see here that what we saw was a response rate of almost 50%. So measuring it shrunk, tumors shrunk in the patients who took the medicine, and almost half of them had it shrink by a pre-specified amount. So that was good news. Now, the other thing that was really cool with this, not only did kidney tumors get smaller, but so did hemangioblastomas in the CNS, so did pancreatic neuroendocrine tumors. So showing that, again, these other manifestations of VHL were getting some improvement taking this medicine, belzutifan. This is showing essentially that people were able to stay on the medicine for quite a good amount of time. So yes, it does come with some toxicities, but most of those were quite manageable. This is showing the number of times patients had surgery. So essentially to the left of that line that comes down, you can see lots of dots. And that's every time a patient had to have had surgery. And then you see that line come down when they started belzutifan, and the number of dots to the right of that line is much smaller. So essentially we're able to put many of those VHL kidney tumors and keep them from growing so they're not going to hit 3 centimeters, so we don't have to do another surgical intervention on that kidney. So really neat to be able to see that. This is talking about one of the main side effects, which is anemia and hypoxia, but again, those were pretty reasonably managed. I don't think it would be fair to say that this is a cure for VHL, but this is certainly the first time we've been able to see a medicine really be able to alter the growth rates reliably and consistently of kidney cancers as well as the other manifestations of VHL. So very exciting news there. And then just to wrap up, we're going to talk about something that's very important to me personally. This is a trial that's looking at treating patients with metastatic HLRCC associated kidney cancer. So when I was a fellow at the NCI, this was the first trial I ever presented to an institutional review board to get it approved. So this was run by Ram Srinivasan, who's a mentor to me still to this day. You can see the picture of HLRCC associated, what we used to call papillary type 2. We now just refer to it as HLRCC associated. Here you see a defect in the fumarate hydratase enzyme. So if anyone has heard of the Krebs cycle or the TCA cycle, it's the bane of everyone's existence. I can't believe I survived studying it in college and medical school only to make it a big part of my practice. So sort of irony there. But again, the way the cells make energy is altered, and we end up with this tumor that can be very aggressive and unfortunately have poor outcomes. There were no current therapies that were widely recognized as being the standard de facto go-to treatment for HLRCC-associated kidney cancer. This is going to be comparing, in this trial, there were people who had just papillary kidney cancer and HLRCC-associated kidney cancer, and you'll see those on this slide. So in terms of patients who had change in tumor size, you can see on the left the HLRCC patients had a better response in terms of tumor size, with a 72% response rate versus a 35% response rate. 72% response rate in metastatic kidney cancer is impressive. So that was neat. Again, small study, but excited to see that. You can then see here in terms of what was going on in terms of continued response with these swimmer plots. So I drew this line at 20 months, and you can see on the left there are a lot more people who are still on the drug at the 20 months versus this sporadic. So again, seeing a benefit for patients with the FH altered type of cancer. And then looking at survival outcomes for progression-free survival, 21 months versus essentially 9 months. And then for overall survival, 44.6. That was cool. 44.6 months overall survival versus 18.2 in sporadic. So again, really showing new opportunities for us to pick systemic therapies based on our understanding of a patient's genetics, helping us come up with good options that are going to improve length of life as well as quality of life, and certainly would not be possible without patients participating in clinical trials. So again, please ask about clinical trials early and often. And just remember, family history is critical. So when we're meeting patients, for us to be asking about family history, for you to be able to give family history, for us to consider triggers for a genetics eval like we talked about earlier on, and then of course to seek evaluation and treatment at high volume centers with high volume providers like all of the Chicagoland folks who are visiting with us today. Thank you so much for the opportunity to be here. Truly a pleasure. Happy to answer any questions in the last minute. In the back.
I have two questions. To clarify the first one, someone who has kidney cancer, and then are they able to determine if that kidney cancer came from, whether it was sporadic or it came from genetics? Are you able to determine that after the fact?
Yes, so we could essentially, a lot of it would have to do with your family history when you presented the information for the tumor. If there was a concern about it being hereditary, we would be able to have you meet with our genetics counselors, and then they'd be able to run testing. But often we can sort of have a reasonable guide based on some of these other things. Age, is it unifocal, so one versus bilateral multifocal, and did it have any of the histologies that would be associated with some of those specific conditions? Sometimes there are other things that we can see also. If someone has some specific lung findings or uterine fibroids or skin findings that can say, hey, this is really looking like potentially one of these hereditary kidney cancer syndromes. But testing would be the most definitive way to know that.
That makes sense. And then I had a second part too.
Sure. Yeah, typically not with that. Some of those things can all have some common links. So kidney and bladder or urothelial smoking can be a risk factor for both of those. Some of those can both have to do with exposures to certain environmental things. But again, sort of going back to our discussion of familial kidney cancer, there are people, if you can have other cancers in your family that may warrant having a conversation with a genetic counselor just to see if there's something else going on. So we know that some Urothelial, upper tract urothelial, and colon, and something we call Lynch syndrome exists. So not renal cell, but upper tract urothelial. So I would say if you have a strong family history of first-degree relatives with with cancer, consider having a discussion with a genetic counselor. We've got, back, then we'll go second row, first row. Yeah.
Just to expand a little bit on what you just said, cancer, any type of cancer, so there is such a gene that predisposes a person to have cancer if the family line is dotted with different kinds of cancer?
There can be something called Lee-Fraumeni syndrome, which is loss of something called P53, which can predispose to a bunch of different cancers, but typically they're not related through genetics. But again, if there's a strong family history of having lots of people with cancer, it would be something to consider having a conversation. Yes?
Yeah, why is papillary 1 and 2 combined now? When I saw the slides, it's obvious that the cells look...
Yeah, they're no longer combined, they're just called different things now. So papillary is now papillary, and that would be sort of your old papillary type 1. And then papillary type 2 is now called HLRCC associated kidney cancer.
Hi.
Hey.
I have a confirmed germline of SDHB, and I have, my subtype is chromophobe. So I had my daughter test, and she is positive, germline for SDHB. What do you recommend? Because I know I didn't have any symptoms when they found my kidney cancer. Should she go and get scanned once a year or just at a certain age?
May I ask how old is she?
She's 33. I was
Okay.
diagnosed at 46, 7. 46, 7.
So for a lot of screening, especially in younger folks, I try to avoid CT scans because there is some radiation exposure. And if we're going to be following someone for a long time, decades, that adds up. So for very young kids, we often talk about ultrasounds to start off because they're easy, non-invasive. You don't go in a machine. There's no needles. For other folks, we often talk about MRI because you get very good images, but there's no radiation exposure.
How often would you recommend something like that? Once a year, every 5 years?
I would start with get one and then see what we've got, and then I often, for many things, do once a year, and then sort of see where we're at. But start with something.
Yeah.
And then, thank you.
Great presentation. Amazing football teams.